Okay, so long bone fracture. Due to this, fat globules will be released into this circulation, and in 1 to 3 days, it can cause several systemic manifestations, including petechial rash, neurologic hypoxemia, and neurologic abnormalities. And these fat globules make this circulation little sluggish, due to which cellular hypoxemia at the cellular level occurs. And hence, the heart heart receives information that it has to beat more quickly, because sufficient oxygenation is not occurring, and there will be tachycardia as well as tachypnea and petechial rashes over the chest area. So fat embolism is very common consequence unless properly treated in advanced trauma care centers, where tissue plasminogen factors are administered. Tissue prothrombin inhibitors is administered, and petechial rash in the frontal or ventral parts of the body, like chest, neck, conjunctiva, in fact, are very common for fat embolism. And DVT mainly occurs due to immobility. Occurs in cases of stasis, often predisposed by long-time standing and smoking. Smoking is a very good aggravating factor for DVT. Okay, next question. A 42-year-old patient comes to your clinic with a complaint of abdominal pain after drinking water from a sealed mineral water of a particular brand. So on examinations, nothing is found abnormal. You assure the patient and tell him to follow up the next day. Soon after that, you get a few more similar cases with the same complaint. So what should be the next step you should do? Inform the police to investigate the matter along with the medical team. Ask the local authority to ban that brand. Advise prophylactic antibiotic for everyone of that locality, every person of that locality. Give this advise anti-spasmodic medicine to counter the abdominal pain to that patient, and just release him. Release everyone. So as you can see that this case is not bound to a single person. This has gone beyond a single person, and similar cases are occurring from the same drinking the same water from a particular brand or from particular shop. So what you should do, you should inform the police to investigate the matter along with medical team. So in case of epidemic outbreak, especially this is another question can be asked from this question. Here it has been asked that what would be your next step? Can be what type of outbreak is this? This is a point epidemic. What type of epidemic? Point epidemic. Just from one single shop or single source. Point source epidemic. Okay, point source epidemic. Point source epidemic suddenly rise and suddenly falls. Suddenly rise and suddenly falls. So in case of epidemic outbreak of or any situation where there's a large number of similar cases, the first step is very important to confirm the diagnosis whether the outbreak has really occurred or not. In many cases, it is found that people get influenced by others and keep complaining the same. It's called mass hysteria. like situation. So in such cases, the matter needs to be investigated by the administrative authority along with the medical team. Okay, so this is a very this is a question from PSM, an important question as well. This type of question do come in FMG, and this epidemic outbreak is this topic, epidemic outbreaks, point source epidemic. This topic is very important from PSM. Okay, so next. Okay, 52-year-old man's hand, as it is shown here. He complains of loss of range of motions and functions of the hand movement. Loss of motions, range of motions, various motions and functions of hand movements. Which of the following is correct? Now, maybe the picture is not good, but if you see very minutely, you can understand that there is contractures. There is contractures. Another. There is contractures. So which of the following is correct? Cause due to accumulation of uric acid, condition is painful, thumb is painful, no definite treatment is present. And the answer is no definite treatment is present. Now, first of all, two things. First of all, what case is this? So directly they asked about the cause and the treatments and all, and the statements regarding it. But what case is this? This case can be said as this is first of all tabletop test. This is tabletop test, very common test, that is just is a table and keep the hand here. Keep the hand on the table and extend the hand. That's it. And you need to observe. And if there is contractures showing, then this is typical diagnosis of Dupuytren's contracture. Dupuytren's contractures. The reason, the etiology is idiopathic etiology, and obviously no treatment, no definite treatment is present. What happens in this case is the fascia or the tissue of the palm is thickened and tissue lining shortens. So puckering of the skin limit the ability to strengthen. Okay, and the test is Dupuytren's contracture test is tabletop test. Idiopathic reason, no definite treatment. Features of painless conditions mostly affect ring finger, then little finger, then thumb. Mostly affect ring finger. This finger, this is the typical. If there is any typical image of Dupuytren's contracture, you can see they have shown the ring finger only. Most common joint involved is metacarpopharyngeal and then PIP joint. Proximal interphalangeal joint. So most common joint is metacarpopharyngeal. Clostridial collagenase injections have shown promising result. This can be a little a positive fact regarding the treatments, but as of now there is no considered treatment for this condition. Okay, next question. A 22-year-old student is presented in your clinic with trismus and hot potato voice. Trismus and hot potato voice. The above physical examination is shown. What is the diagnosis? So the physical examination is revealed trismus and hot potato voice in a 22-year-old student. Diagnosis is peritonsillar abscess. Now, what are the points? First of all, hot potato voice. This is a typical hot potato voice, typical of peritonsillar abscess, quinsy. In common language, quinsy. Hot potato voice. Number 2, trismus. Another point is very important. That is the profession of the work of this patient, that is student or teacher. They have this. They have to shout and study or teach or whatever. So they have this peritonsillar abscess due to extreme shouting or continuous shouting. Peritonsillar abscess is quite common. So this patient is most probably has peritonsillar abscess or quinsy, and it is shown here with tongue depressor. This is uvula. Okay. So obviously not epiglottitis, infectious mononucleosis, no. Chronic tonsillitis, no. Tonsillitis, if you can palpate tonsils, and it is peritonsillar abscess. Okay, next question. Okay, next. Okay, peritonsillar abscess, that is the progression of tonsillitis, can lead to peritonsillar abscess. So first of all, tonsillitis may occur. Then there may be inflammation and there may be abscess. Inflammation of supratonsillar soft palate and surrounding muscles occurs. Pus collects between fibrous capsule and superior constrictor muscle of pharynx. And the common infectious agents may include Streptococcus pyogenes, especially, and other anaerobes are Fusobacterium, Peptostreptococcus, Prevotella, bacteroids. Now, suspected, if peritonsillar abscess is suspected, then what we should do? First of all, history of the recurrent tonsillitis should be taken. No prior history of the recurrent tonsillitis. If there is history, then if there is history of recurrent tonsillitis, then we will go for abscess tonsillectomy. Whereas if the case is for the first time, then we will go for needle aspiration. Pass, if pass is obtained, then it can be peritonsillar abscess, odonophagia, dysphagia, and trismus habit. If there is presence of peritonsillar abscess, odonophagia, dysphagia, then outpatient treatment with analgesic, antibiotics, and close follow up. And if symptoms again recur, if recurrence occurs with the symptoms, then we go for aspiration. If there is no recurrence of the symptoms, then we continue with the present treatment. If there is no pass, if there is the pass obtained has no evidence of abscess, odonophagia, dysphagia, and along with odonophagia, dysphagia is absent also, then we go for, so there is no abscess, there is no odonophagia, dysphagia, trismus, then we go for inpatient treatment with IV antibiotics and fluids. And if pass is not obtained, then peritonsillar cellulitis may be the diagnosis. Now, if it is found that peritonsillar cellulitis is not present, then uncertain diagnosis, consider referral to ENT. We will do further checks, further imaging test. And if there is cellulitis, not imaging, blood test and other test, or we can go for INT, incision and drainage. If there is cellulitis, then inpatient treatment with IV antibiotics, fluids and analgesics. So cellulitis has occurred, so antibiotics, fluids and analgesic treatment for the bacterial infections. Okay, so this is about peritonsillar abscess. Now, next question: a 3-year-old baby girl came to your clinic with chest infection and mild fever. With chest infection and mild fever. On examination, you find continuous murmur. So chest infection and mild fever. On examination, there is murmur. She weighs 7 kg weight and her mental development. Anyway, this is wrong, obviously. Oh no, okay, 7 kg weight. Okay, no. She weighs 7 kg weight and her mental development is good enough. Her sputum test negative for AFB. Her parents say that she suffers from such kind of fever very frequently. What would be the diagnosis? Okay, so 3-year-old chest infection with mild fever, continuous murmur, mental development is good, sputum test is negative for AB, and she suffers from such kind of fever as well, as complained by the from the parents. Diagnosis is PDA. Very evidently, you see continuous murmur. They have already said continuous murmur. Out of all these, continuous murmur is most evident in PDA. If I forget about other features like chest infection, mild fever, mental development, and all other features, whatever given, just continuous murmur is quite evident in PDA, and it's not so evident in other conditions. It's not found in other conditions. In PDA, she has poor weight. Weight is poor. No she has poor weight, but no cyanosis is mentioned, because when PDA increases or when age of the patient increases, cyanosis starts appearing. Right after 3 to 4, within 3 to 4 years old, with patient with PDA shows evidence of cyanosis, because oxygenation is not sufficient at this age. At very small age, like 1-year-old, 2-year-old, or maybe few months of age, PDA can the patient can make it with patent ductus arteriosus. But with a ductus arteriosus in place, they can make it. But when the patient grows up to 3 years old or becomes 4 years old, then this ductus arteriosus and the mixing of oxygenation deoxygenation blood cannot be tolerated by the body, and cyanosis starts appearing. It's not sufficient for the body from that age. Now, pneumonia generally presents with much severe symptoms, including dyspnea and tachycardia, which is not present in this case. And for TB, there is a negative sputum test, so no question of TB. So pneumonia, TB is, and we will not think about VSD due to the murmur. So continuous murmur is in PDA. He also painful the face. the important portion is painful while touching the face and throughout the face. The discharge from the nose. So CT scan was ordered, and it's where is CT scan? Okay, this is the CT scan actually. CT scan should be in that slide as well. Anyway, CT scan was ordered and it's shown here. Likely diagnosis is nasopharyngeal carcinoma. Now, some of the important points to be noted here are cervical lymphadenopathy is present at presentation. Trigeminal neuralgia occurred. That is why there is painful attacks and sense of burning. This is trigeminal neuralgia. Hearing loss, conductive hearing loss occurs. Bloody discharge from the nose. Another important is the image clearly shows the features, confirms the case. This is nasopharyngeal carcinoma. You can compare this with a normal image of CT. This is an abnormal lesion that is evident in this CT. And along with the image and the features mentioned here, we can go for NPC. A good diagnosis of, and do remember this trigeminal directly trigeminal neuralgia is burning sensation occurs during touching the face. That patient will not tell the trigeminal neurologist. So, no diagnosis. Now, NPC is caused by station peoples. Fossa of Rosenmiller, very important shaped fossa on the lateral wall of the nas. Carcinoma of the nasopharyngeal type, undifferentiated carcinoma of the nasopharyngeal. Important, which is also mentioned in the case, in this particular case. Other features that we can get is leading to glue ear, leading to conductive hearing loss. Cranial nerve pulses, trotostrad, very important. Always remember NPC shows trotostrad. Morgagni syndrome, ipsilateral palate palsy, conductive hearing loss is confirmed. Okay. The treatment is radiotherapy, can be the mainstay, and surgery is reserved for who fail to respond to the radiation therapy. Okay. So this is about NPC nasopharyngeal neck lamp at the earliest, or nose lamp at the earliest. Sore throat, breathing trouble, difficulty in speech, epistaxis, trouble hearing, headache, and late symptoms can be cranial nerve involvement, trigeminal. Already the patient, the case is of late stage. later stage. That's why we have seen trigeminal here, trigeminal neuralgia can be present. So in this case, TN is present. So CN5 is involved in this case. So basically, you can see the case belongs to the late symptoms, late stage in PC. And diagnosis, proper diagnosis, signs and symptoms of NPC, history, physical and diagnostic examination, as well as CT or MRI imaging, blood examination, and at last FNAC. Treatment should be radiation, chemotherapy. If fails, then go for surgery. And nowadays, for later stage, we go for combined approach, especially for later stage. We go for combined approach using both radiation, chemotherapy, surgery, again radiation, chemotherapy, like this. Radiation and chemotherapy, surgery, again radiation and chemotherapy. So like this is the neoadjuvant therapy. We combined approach we do for later stage most commonly. Okay. Okay, next question. A 42-year-old man came to your clinic. His lab report shows he has gross hematuria. Gross hematuria following infection of urinary tract. Now, this is not the first time. He had gross hematuria almost every month. So the kidney biopsy reveal the mesangial region in the above. What may be the diagnosis? And the answer is nephropathy. So from the clinical feature, you see hematuria is there. So glomerulonephritis. In the image, you can see these arrows. This arrow. This arrow shows endocapillary proliferation. This is endocapillary. This endocapillary proliferation. This is proliferated. While the arrow below, the above one, and the below shows mesangial hypercellularity. So this is endocapillary proliferation. This is endocapillary proliferation. And the arrow below shows mesangial hypercellularity. Recurrence, clinical features, specimen all concludes the cases of IgA nephropathy. So this is about IgA nephropathy. IgA damages the basement membrane, so blood and other proteins can pass through. And most significantly, you can see hematuria. Okay. So these are some treatment algorithms. Like if GFR loss occurs, then acute kidney injury due to macrohematuria or other common cause, then supportive therapy. For nephrotic syndrome or RPGN, we go for immunosuppression therapy. If GFR is less than 30 to 50 ml per minute, then we go for supportive therapy. No immunosuppression is given other than if it is rapidly progressive glomerulonephritis or RPGN. Proteinuria, if it more than 0.5 to 1 gram per day GFR normal or slowly and more than 30 to 50 ml per minute, then supportive therapy should be continued and around for at least 3 to 6 months. And then we can do two things: either continue the supportive therapy alone if proteinuria is less than 1 gram per day and GFR decline less than 30% per 6 months, or add corticosteroid if proteinuria is increased more than 1 gram per day or progressive GFR loss occurs. Then we will go for adding corticosteroids. Okay, next question. A 15-year-old male came to the hospital with complaints of mild gross hematuria. Mild gross hematuria. No other features were found. Doctor couldn't conclude at that time. He returned back. After a few days, hematuria increased and some vision problems appeared. Some vision problem appeared, and his parents also complained that he started developing hearing problems as well. So kidney biopsy was done, showed presence of foam cells in the interstitial cells. Glomerulopathy, and the answer is Alport syndrome. In Alport syndrome, hematuria occurs at the earliest, starting with hematuria. Starts hematuria. Starts with hematuria, and later ear and eye involvement occurs in Alport syndrome, and later ear and eye involvement. The triad of kidney, ear, and eye is the characteristic of Alport. In ear, sensorineural deafness (SNHL), and in eye, posterior in eye. To 20 years, cells are observed in light microscope. Splitting and lamination of lamina densa, basket wave appearance is found under electron. Very important. This is because these are typical histology findings. If you know that in Alport syndrome, there will be presence of foam cell and thinning of or basket wave is very easy to, and in light microscope it is foam cell. While in electron microscope this is thin or basket weave appearance. Basket wave appearance. Thin GBM or thinning, progression of thinning of GBM. Glomerular basement membrane. So basically, Alport syndrome is a genetic condition characterized by kidney disease, hearing loss, eye. Most affected individuals experience progressive loss of kidney functions, usually resulting in end-stage kidney disease. Next question. Vaginal discharge. Mucus discharge. She complains of during urination. And also experience also experience increased bacteria less than 10 to 5 10 organisms per ml of. So what you can do as a, the answer is starting from amox 500 mg TDS 3 times into 7 days. Now we will see. First of all, the pregnant woman of 22 years old had vaginal discharge, which is mucopurulent type. Mucopurulent type. That is very important and gives feature. Then pain during urination. Pain during urination, increased frequency of micturition. So one of the biggest factor of chlamydial infection with a frequent micturition and dysuria, it points towards chlamydial infection alone. The diagnosis can be done using NAT or PCR or vaginal swab culture. Chlamydial infection is the most common cause of PID less than 2 are more prone to get chlamydial PID. It is absolutely wrong because the same features are seen in gonococcal infection as well. Very important point. Same features found in gonococcal infections. But as they 10 to the 5 organism per ml of urine, this feature is very much particular pathognomic of chlamydial infection. That's why this in our case discussion. This vaginal discharge, mucopurulent vaginal discharge, you can understand very well that what is the diagnosis. But here we have some confusion. Like presence of bacteria less than 10 to the 5 organisms is chlamydial infection. So in this case, vaginal swab culture can obviously be taken out, but before anything else, it is more better that you start amoxicillin 500 mg TDS for 7 days. And ceftriaxone is used in gonococcal infection. So as it is not gonococcal infection, we have not chosen this option A. We have chosen the option C because from the features, especially this, from the other features, there was a confusion whether it is gonococcal or chlamydial. Because if it is gonococcal, then we will use we will choose option A. If it is chlamydial, then we will choose the option C. But you see, it revealed that presence of bacteria less than 10 to the power 5 organisms per ml of urine, and so it is not gonococcal but chlamydial infection, and that's why we chose option C. That's why we chose option C, amoxicillin 500 mg TDS for 7 days. If it is gonococcal infection, then most commonly we use ceftriaxone for gonococcal infection. So we could have chosen ceftriaxone 125 milligram for gonococcal. And here we can give treatment only to the patient. There is no essential point of giving to the sex partner or husband. But in gonococcal infection, both the partner, I mean the patient as well as her partner, should be treated along with them. Okay. So anyway, next question. A 52-year-old woman from the low socioeconomic status came to your clinic with irregular vaginal bleeding, complained about vaginal discharge with offensive smell. Revealed anorexia. She has anorexia. She has increased urinary frequency, sometimes unilateral pelvic pain. What should be done? USG, CT, MRI, biopsy. So let's see why directly we will go to biopsy. Now, there was irregular vaginal bleeding, which is of offensive smell, irregular vaginal bleeding with offensive smell, and anorexia, increased frequency, urinary frequency, discharge points towards cervical or biopsy, hysteroscopy, colposcopy, cystoscopy, proctoscopy, conization, endocervical curettage. So none of these options are present in our question options except biopsy. So the list does not contain ABC. So we should go for biopsy, obviously not USG, CT, MRI. So what are the clinical features of cervical cancer? Then how can we understand? First of all, for vaginal bleeding, offensive discharge, creamy at the early stage and brownish and offensive in the later stage. So it changes, not that it doesn't change like in other vaginitis or vaginosis we see. There will be deep pelvic pain along with this bleeding and discharge. In case of bacterial infection, vaginitis, there is hardly deep pelvic pain. Deep pelvic pain is quite significant in case of cervical cancer, along with bleeding. Urinary continence, dysuria is there. Increased urinary frequency is there. Uretary colic pain, rectal pain, low back pain, triad of sciatic pain, leg edema, hydronephrosis, weight loss, and anorexia. And malaise. Obviously, anorexia is not at all evident or not at all present in vaginosis and other infections. So first of all, when you will see regular offensive smell, it comes in our mind that whether it is vaginosis or something like that. But you see, without any taste, what can be the probable diagnosis? And if they give chlamydial infection, bacterial vaginosis, cervical cancer, then the question will become little tougher, because the first thing that comes in our mind, like infection, not at all the cervical cancer, but you see irregular bleeding, unilateral pelvic pain, urinary frequency, anorexia, these are not at all present. So we need to be little vigilant about what it is telling. Although it is offensive smell, irregular vaginal bleeding, then also it points towards cervical cancer. So firstly, staging should be done and then treatment should be started accordingly. And but in order to do the staging, the standard protocol that is has to be followed, where the mentioned investigations are biopsy, hysteroscopy, colposcopy, cystoscopy, proctoscopy, conization, endocervical curettage. Okay, next question. A boy of 4 years old was brought to you with the complaints of hematuria. And you see, you revealed that the child is also having fever. And CT scan was given and it revealed a non-calcified soft tissue mass in the left kidney. Non-calcified soft tissue mass in the left kidney, and the mass measures 9.2 into 7.4 into 10.2 centimeter, and the adjacent bowel loops are displaced due to the presence of this mass. The pancreatic tail is effaced and also displaced towards the right, and the mass partially effaces the adjacent psoas muscle, and patient is having vomiting as well. So what can be the probable diagnosis? Neuroblastoma, nephroblastoma, primitive neuroectodermal Hirschsprung disease, and the answer is, in general, we know the name Wilms tumor. It's type of tumor containing epithelial and connective epithelial in origin, as well as connective tissue elements are also present, arising from embryonic nephrogenic tissue. Embryonic nephrogenic tissue. They are discovered during the first 4 years of life, especially, and they are normally situated at one or the other pole of the kidney, but sometimes bilateral tumors do occur. So bilateral tumors do occur, and there may be involvement of abdominal mass as well that grows rapidly while the general condition of the patient may deteriorates. Fever is a feature, but it disappears when the patient is tumor is removed. Hematuria implies extension of the tumor into renal pelvis. Because the tumor extends into renal pelvis, there is hematuria. Metastasis occurs early, which can be mainly evident by CT scan. Liver, bone, and brain metastases are rare, and lymphatic spread is uncommon. Nephrectomy can be performed. Nephrectomy should be performed as soon as possible, followed by radiotherapy with or without chemotherapy. Partial nephrectomy may be done in patient with bilateral disease. Partial nephrectomy can be done in the children with bilateral disease. 80% of children less than 1 year of 5 or 4 of 5 80% of the children less than 1 year can have this disease, and but the prognosis is not so good in older children. For example, in this case, 4 years is older for Wilms tumor. So prognosis is not so good. So the image and other features seen, we can say is Wilms tumor nephroblastoma. In fact, this is the mass. This is the mass, and adjacent bioloops are also displayed. So if we do not go for the CT scan, it's not non-calcified mass. That's why this shadow, soft tissue mass, okay, in the left kidney. Non-calcified soft tissue mass in the left kidney. That's why this shadow has come, as it is not calcified one. And the clinical features, that description that they have given, the descriptions are quite sufficient for you to understand. Okay, and this is about Wilms tumor, very important. Wilms tumor has come in FMG many times. Very important tumor for pediatrics. Okay, pediatric patients. Okay, next question. A 14-year-old old boy presents with acute onset right scrotal pain. Acute onset right scrotal pain, and the pain is not relieved on elevation of the scrotum. And he has no fever or dysuria. So acute onset right scrotal pain, not relieved on elevation of the scrotum, has no fever or dysuria. Testis is enlarged and tender. Routine urinary examination is normal. No history of trauma. Which of the following is the most appropriate management? And the answer is immediate exploration. So the feature shows right scrotal pain, no fever or dysuria, enlarged testes, normal routine examination, no history of trauma. These are the features. All this implies it may be the case of testicular torsion. Testicular torsion. Now, the condition is most commonly seen in the age group of 10 to 25-year-old. There is sudden agonizing pain. This, remember this term, agonizing pain in the groin and lower abdomen. This is very typical of testicular torsion. The onset of redness of the skin after 6 hours or so and mild fever 6 hours. Redness of the skin after 6 hours and mild fever shows that the case may be of epididymoorchitis, but there is no mention of these features. Right scrotal pain is there. Right scrotal pain is there, but there is no redness. We have done a case of epididymoorchitis. Trans-illumination test is positive there in that case. And we can see there will be redness of the skin. But in this case, there is no redness. Mild fever is there, yeah. Oh, no fever is there, so no question of epididymoorchitis, because in epididymoorchitis there is inflammation of epididymis and testis, and that is why there will be fever, there will be redness, but here nothing is evident. No fever, no redness. Even elevation of testis reduces the pain in epididymoorchitis. That is very important clinical point. But here you see the pain is not relieved in elevation of the scrotum. So in epididymoorchitis, you must remember mild fever, redness of skin, relief of pain on elevation of scrotum. These 3 points to detect diagnose epididymoorchitis clinically. Okay, do remember this, but there is no mention of this relief of, in fact, pain is not relieved on the elevation of the scrotum. So we can differentiate that is not epididymoorchitis, rather it is testicular torsion and must be intervened with immediate exploration. Okay. It's important, very important question. Okay, now this is plane of sagging shoulder, walks in warehouse, and see the inspection. We can observe the patient. Which one of the following below is true? Prescribing electromyography is a waste of time. This is caused by injuries to long thoracic nerve. Internal rotation is advised as a part of the management by inactivity or sedentary lifestyle. So which one of this is true? Number B is the true. Now, this is first of all, evidently this is winging of scapula. You see the medial border of scapula is prominent. That is the feature of winging of scapula. So scapular winging or winging of scapula. First of all, electromyography prescribing this is a waste of time. Which one of the following statement below is true? So electromyography can be done actually. Internal rotation is also not at all advised. In fact, external rotation is advised. External rotation is advised. and obviously not caused by inactivity or sedentary lifestyle. In the question only, they have said that he works in warehouse for unloading heavy boxes. In fact, this occurs due to working, holding heavy loads, holding heavy loads. So winging of scapula is mainly caused due to the injury caused to dorsal scapular nerve supplying the rhomboid, spinal accessory nerve supplying the trapezius, and long thoracic nerve supplying the serratus anterior. So this is true. Number B, this is caused by injuries to long thoracic nerve. So electromyography is often prescribed and external rotation is advised. And in this case, that is winging of scapula occurs due to trauma, heavy lifting, and even due to allergy as well. You should remember all these points. So winging of scapula, this is called winging of scapula, that you know. But these other features that you just came that you can see here, that electromyography, then external rotation is advised. These are very important points. You must know the the management profiles, because winging of scapula that is present, these cases in winging of scapula, this is present in anatomy. But what is the management options? Electromyography as part of the investigation options we can do, and external rotation can be done. External rotation as part of the management. Okay, next question. A 30-year-old female is presented with headache and post-nasal yellowish thick discharge. Headache with post-nasal yellowish thick discharge. She complained of nasal blockage at the night times. And pain, tenderness, pressure around the eyes. CT of the sinuses, sinus CT is advised and it's shown below also. Likely diagnosis. Sinusitis, acute sinusitis. Typical case. You see this above CT reveals an extensive mucosal thickening in the paranasal sinus. Mucosal thickening in the paranasal sinus. Sorry, not this. This. This is mucosal thickening. That's why radiolucent. Mucosal thickening. A paranasal sinus with almost entire opacification of the maxillary and ethmoid sinus. Opacification of maxillary and ethmoid sinus. Osteomeatal complex are obliterated, cannot be seen. Nasal septum is midline. Nasal septum, this is nasal septum. And these two are entire opacification of maxillary and ethmoid sinus is seen. So all these features, CT features, all these CT features are acute sinusitis. Belongs to acute sinusitis. And you see complaint of nasal blockage at night times and night times. And pain, tenderness, and pressure around the eyes, typical features of acute sinusitis are present. Okay. According to time, this nasal blockage occurs in sinusitis. There will be pain and pressure around the eyes due to mucosal thickening and maybe accumulation of fluid. Sinusitis can occur. Okay, so, and there is a factor of allergic factor in acute sinusitis. Allergic factor. That's why this fluid accumulations occurs in these cases. So you see symptoms progress over 2 to 3 days: nasal congestion, discharge, localized pain, tenderness or pressure sensation, cough due to postnasal drip, that is different, halitosis, bad breath, malaise, erythematous, nasal mucosa, purulent secretion in the middle meatal area. Then percussion tenderness will be there, will be evident. If it is maxillary sinusitis, then we can get unilateral pain over the cheekbone, maxillary toothache, periorbital pain, temporal headache, pain worse if head upright, pain better if head supine. So all these symptoms, features, clinical features of sinusitis. In fact, in ethmoid sinusitis, there will be canthal pain, medial periorbital or temporal headache, which is worsened by valsalval maneuver, or if the patient lies in supine position. Canthal pain. This medial canthal pain. This is medial canthus. Okay, the head. Sphenoiditis, retroorbital pain in sphenoiditis, temporal pain, vertical pain, often deep-seated headache with multiple foci, pain worse supine or bending forward, frontal headache, pain worse supine, control infection, facilitate sinus ostial patency, provide relief of the symptoms, evaluate and treat any predisposing conditions to prevent recurrence, oral antibiotics, topical and systemic decongestants, and pain medications. Secondary medications like guaifenesin can be given, antihistamines. Just I said, there is an allergic factor in sinusitis, so antihistamines are quite used in sinusitis, and it's very much, the result is much improved. Result is can be very positive. Okay, sufficient result can be obtained after giving antihistaminic therapy. Treatment duration should be 10 to 14 days. Like amoxicillin 500 mg, augmentin 500 mg, trimethoprim sulfamethoxazole can be given, azithromycin can be given, and erythromycin sulfamethoxazole can be given. Maybe best choice for pediatric patients. Okay, that's it about sinusitis. Okay, next question. A man of 28 years old who works as a construction labor is brought to the emergency department with nausea, vomiting, abdominal pain. All this started after the ingestion of cheap alcohol ingestion. Which ingestion of cheap alcohol, which the labor has brought from someone, and CT scan was shown, and it reveals bilateral symmetrical low attenuation at both putamen. Next step. What should be the next step? Cheap alcohol means methanol. Methanol most commonly. So from the CT itself, we can see it implies the man is not only consume alcohol but also consume methanol in place of ethanol. So methanol is cheaply sold as ethanol, and methanol consumption causes several problems, including gastroenterological, neurological, and at last visual disturbances. Even it can cause unconsciousness up to death. So first step of methanol poisoning is to start IV ethanol, which has higher affinity for alcohol dehydrogenase compared to methanol 1,4 in an effort to reduce the production of formate. Because if methanol combines with alcohol dehydrogenase and metabolism starts, then there will be production of formate, which produces all these features like gastroenterological problems, neurological abnormalities, visual disturbance, unconsciousness, even death. So what we can do by giving ethanol has much higher affinity towards alcohol dehydrogenase, and we will attract alcohol dehydrogenase towards ethanol, and we will not allow methanol to metabolize and produce vomit. And hence, all these features can be prevented. And we will use alcohol dehydrogenase. We will exhaust the alcohol dehydrogenase and methanol will be excreted as it is. And thus we can prevent the formation of vomit and hence the clinical features presented here. Very common question for FMG. All these are very common questions. Mostly all these are very common questions. In fact, these cases are not only can give you a concept for solving clinical questions, case-based questions, but also can be contributed to solving one-line or direct question as well. Okay, all these can be like they can ask you on methanol consumption. What is the antidote of methanol consumption? That is ethanol IV, not oral ethanol, IV ethanol, so that it will be bypassing the first pass metabolism, and there will be quick onset of the action. Okay, next question. A 29-year-old young female came to your clinic with complaints of suprapubic pain. Suprapubic pain, urinary frequency, dysuria. She also passed bloody urine in the last 30 minutes. So urinalysis was advised and result shows she has pyuria and no white cell cast. On physical examination, she has suprapubic tenderness on palpation. Which of the following is the most probable diagnosis? So cystitis, chronic pyelonephritis, acute pyelonephritis, vancomycin. And the answer is cystitis. In this case, what happens? You see pyuria and hematuria, that is bloody urine in the last 30 minutes. So you need to, it should come in your mind that hematuria is not directly written, but bloody urine in last 30 minutes is written. That means hematuria. Pyuria and hematuria is present without white cell cast. So always remember this formula, like pyuria plus hematuria minus white cell cast. This diagnosis of cystitis. Do remember this formula. Those who has acute pyelonephritis, the patient are presented with fever, leukocytosis, flank tenderness, urinary white cell cast. Urinary white cell cast is there and fever is there. Here, do we have fever? No, I think no fever is there. Okay. Suprapubic pain is there. Urinary frequency and dysuria is the pain during urination. Chronic pyelonephritis comes with urinary tract obstruction, which is obviously not present here, and repeated inflammation of the kidneys. So this is about cystitis. Cystitis, no fever, suprapubic pain, urinary frequency, pain during urination, that is dysuria, hematuria, pyuria, and no white cell cast, absence of white cell cast. Pus can be there, that is pyuria. Pus can be there in urine. Okay, next question. A 12-year-old boy is brought to your clinic with injury to the left arm while playing football. He has complained of diffused pain and reduced range of movement. Diffused pain with reduced range of movement. The parents complained that their boy child went to play football in spite of the fact that he had low fever. So low fever is also there. X-ray shows now X-ray is shown below. So what is the likely diagnosis? What is the likely diagnosis? Now see, X-ray shows there is mid diaphyseal left humeral lesion, which has a permeative appearance and lamellated periosteal reactions. Now let's see the X-ray. Here you can see periosteal reactions. Here the periosteal here the periosteal reactions are there. Periosteal reaction, you can see very finely that a membrane or a line has gone increased elevated from the from the from the two lines of the bone. You can see one line has elevated. That is periosteal reaction. Periosteum elevates. That is periosteal reaction. There is aggressive bone lesion. So any fracture is omitted. And regarding the C, giant cell tumor, it occurs between 20 to 40 years old, and there is a large lytic, giant cell. That's why giant cell it is called as giant cell. There should be a large lytic eccentric lesion, which should be visible in X-ray. Here is no lytic, large lytic. The size will be very big. Large lytic eccentric lesion, which is not visible here. So nothing is found such. Ewing sarcoma occurs between 10 to 20 years old male usually, and features are shown. In the X-ray also shows Ewing sarcoma is the most likely diagnosis. Features like mid diaphyseal left humeral lesion. Mid diaphyseal left humeral lesion here, which has permeative appearance and lamellated periosteal reactions. In this portion, okay, periosteal reaction is there. This periosteal reactions. So if you see the X-ray very minutely, then you can understand there will be some elevation of periosteum from the normal axis of the bone, from the straight line of the bone. The periosteum will elevate. Okay, next question. An intrauterine pregnancy of 10 weeks of gestation is confirmed in a 31 years old, gravida 5 and para 4. Gravida 5 and para 4. Okay, she has amenorrhea now. Now she has amenorrhea. She has IUD in place, and patient wants the pregnancy to continue. Once the pregnancy to continue, the string of IUD can be seen protruding from the cervical os. Cervical os, which one of the following should be done? So You see, the patient was gravida 5 and para 4, that means 5 times she was pregnant, and she had given live birth of four children, four children, and this is the fifth one she is experiencing. So already 4 children are there, and she is having one pregnancy now. Okay, fine. String of IUD is present. So remove the IUD to decrease the risk of malformation. Leave the IUD in place without any other treatment. Remove the IUD to decrease the risk of infections and terminate the pregnancy because of high risk of malformation. So what should be done? Let's say remove the IUD to decrease the risk of infection, not malformation. So patient with IUD in place with amenorrhea should undergo pregnancy test first of all and pelvic exam. Intrauterine pregnancy can continue rupture of membrane, that is PROM, birth. So it is advisable to remove the IUD to decrease the infection of the infection. Okay. So IUD should be removed to decrease the risk of infection. And any other problem is not there because already the patient had no miscarriages. Patient had no miscarriages. Another no problem. So just it was about IUD. IUD is seen in place. So what should be done in case of IUD in place with pregnancy? What should be done? Very important question. Okay, next question. A primiparous woman of 40 years old is suspected, 40 years old, primiparous woman, suspected to have endometriosis and subject to diagnostic laparoscopy. Finding shows uterus is to be normal, both ovaries shows presence of chocolate cyst. Endometriotic deposits are seen on the round ligament of the right side, both the fallopian tubes and pouch of Douglas. Moderately dense adhesions are present between the fallopian tubes and pouch of Douglas. So the treatment of choice. So the first of all, patient has endometriosis. Uterus normal. Ovaries show presence of chocolate cyst. Endometriosis, chocolate cyst. Endometriosis and endometriotic deposits are seen in the round ligament on the right side. So right round ligament, on the right round ligament. And also in the fallopian tube. So both the fallopian tubes and pouch of Douglas. Moderately dense adhesions are present. Dense adhesion present between the fallopian tubes and pouch of Douglas. Between fallopian tubes and pouch of Douglas, POD. So treatment of choice. Fulguration of endometriotic deposit. In this case, there is a dense adhesion and chocolate cyst. That is the big problem. These two. Now this cannot be fully managed by drugs. So there is a need of some surgical intervention. Now in endometriosis, conservation surgery is preferred for women who have completed childbearing, in this case like primiparous, and do not want any more child. Do not want, obviously 40 years old woman is determined that she doesn't want anymore. So for this type of patients, we can go for hysterectomy with bilateral oophorectomy means removal. Oophorectomy means removal of ovaries should be carried out. So before that, conservation surgery has to be done, that is fulguration of endometriotic deposits. Fulguration of endometriotic deposit. Without doing this, we will not go for total hysterectomy with bilateral salpingo, bilateral oophorectomy. We will not go for this. Before we need to do fulguration of endometriotic deposit, that has to be removed, that has to be disappeared, and then we can go for hysterectomy, bilateral oophorectomy. Okay, very important question and very complex also. So many features are presented here, and no need to think of denazole and progesterone therapy. Obviously, there is a need of surgical intervention. So medical management, just forget about medical management only. There is chocolate seeds, there is dense adhesions, endometriotic deposits, most importantly endometriotic deposits. So there will be endometriotic deposits are seen on the round ligament of this right side, right round ligament, both the fallopian tubes and POD, plus adhesion, plus chocolate cyst. So forget about medical management only. Medical management can be given, but not along with surgical intervention. So first of all, endometriotic deposit, fulguration of endometriotic deposit, and then we will go for hysterectomy with bilateral oophorectomy. And this hysterectomy is done. We are going for this hysterectomy with bilateral oophorectomy only because the patient is 40 years old, and she doesn't want any more issues, doesn't want any more child. Okay, that's why. If the patient wants child, then we will just do the fulguration of endometriotic deposit and not go for his hysterectomy part. The next question: a 30-year-old man comes to the clinic with a complaint of fever for more than a week. As part of the history, he reveals that he has valvular heart disease. Valvular heart disease. A detailed physical examination reveals Roth spot, very important, Roth spot on the retina, splenomegaly, and bluish red spot on the palms and soles. He complains no pain, tenderness while touching those lesions on the palms and soles. What could be the possible diagnosis? So this is Roth spot. Diagnosis is infective endocarditis. In infective endocarditis, there is Roth spot is evident on the retina. Fever for more than a week. Is caused often by infection. VHD, valvular heart disease, is associated with vegetation on the heart valve, which makes it prone to bacterial infection. And now, what happens? You need to understand that many bacteria every time can be pumped by the heart into the circulation, causing an enlarged spleen. In this case, painless bluish red spot on the palms and soles are known as Janeway lesions. Very important, Janeway lesions, which are hemorrhagic in nature and hallmark of infective endocarditis. So hallmark of infective endocarditis, remember, Janeway lesion. And Roth spot on the retina again is a classical finding of infective endocarditis, and some other characteristics are oslar nodes, arthralgia, myalgia, persistent cough, petechiae, low RBC count, heart murmur, night sweats, etc. And Duke criteria is useful for the diagnosis. Duke criteria. Okay, 25-year-old woman comes to you with a complaint of fever for at least 10 days. Physical examination reveals diffused abdominal tenderness, slight pale skin, coated tongue. Reports no itching, only itching during the urination, and menstrual cycle is normal. So what should be the diagnostic test? Complaint of fever for last 10 days. Complaint of fever for the last 10 days. Physical examination reveals diffused abdominal tenderness, slight pale skin and coated tongue. No pain or itching. No pain or itching during urination. Okay, no pain or itching during urinations. Menstrual cycle also normal. Diagnostic test. Vidal. That means we are thinking about typhoid fever. Fever along with abdominal tenderness. Remember this again. Fever along with abdominal tenderness. Basically, it indicates enteric fever. And enteric fever in India indicates typhoid, and we will go for Vidal test. Vidal test. So whenever fever with abdominal tenderness will come, you need to go for Vidal test. If it is negative, then it's different thing. But another thing, but you need to do it. But another thing is that fever should be not like 2 to 3 days or just few hours or 1 to 2 days, not like that. For last 10 days, for last 10 days, very important. So blood culture, agglutination test or viral test should be done. Stool culture can be done. Urine culture can be done. And urine culture, the best diagnostic test for detecting the typhoid fever during the first, second, third, and fourth week respectively. So, okay. So in the first week, means first 1 to 7 days, blood culture should be done. If fever plus abdominal tenderness and if this, then not 7, 8 to 14 days, 15 to 21 days, then stool culture, and 22 to 28 days or 30 days and above actually, then you need to do urine culture. But by that time, patient will obviously come. By that time, patient will obviously come. So these are the protocols that when you should give which test during an enteric fever. Okay. So as it is, as in the case, it is 10 days, then Vidal test. Another thing is that abdominal tenderness, pale skin, and coated tongue. All these actually, and no pain and itching during urination of the for the women, and menstrual cycle is also normal. So all this indicates to some enteric fever, and there is no vomiting, there is no nausea, vomiting like that. Okay, so this is about vital test and enteric fever and how to give the test for enteric fever. So Vidal test, to remember another thing, Vidal test is given after 7 days only. Okay, after 7 days, more than 7 days of fever, 7 days of fever, Wait, test is given. Okay. Within the week.
Sure.
Okay. Okay. Next question. An adult male patient with chief complaint of poor sight at night. Adult male patient with chief complaint of poor sight at night. Okay. Already has myopia. Fundus picture is shown. Black spot in the perivascular region. This is the black spot in the perivascular region. What is the diagnosis? Retinopathy of prematurity. In the, now D is eliminated. The clinical features shown in the question is like black spot in the perivascular region and poor sight at night time. Clearly implies that this is a case of retinitis pigmentosa. Do you remember these two features of retinitis pigmentosa? That is black spot in perivascular region. And this is fundoscopy picture, image of fundoscopy. So it can also occur that this image will be given and you need to identify, need to appreciate this black spot in the fundoscopic image result. I need to understand. They have said here already shows black spot in perivascular region. Maybe they will not say. Maybe it will be said as fundoscopy was done and it's shown here. Okay, for IBQ. And you need to understand that one black spot in perivascular region is there along with poor sight at night, adult male patient, and myopic. So retinitis pigmentosa. Okay. Okay. Next question. A partially burnt female dead body is brought to the emergency by her family members. As per the family members, the female got burned somehow and died. Now, post-mortem was done and was found to have blisters containing exudates. And you found a broken hyoid bone and deepened red horizontal line around the neck. There was no such finding in the blood or viscera like lungs. No finding. So what is your conclusion about the cause of death? Cause of death is burning. Burning from kitchen stove and falling in kitchen resulting in hyoid bone fracture. Cause of death is asphyxia and is post-mortem burning. Cause of death is inconclusive, but the burning is antemortem in nature. Antemortem in nature as per the family members. So cause of death is burning, but due to burning, the person has died. The answer will conclude at last. It's not important. First, evaluate. We need to analyze the whole situation. In this case, what is happening? First, you need to think that it is whether it is antemortem or postmortem. That means burn and death, or death then burn. So first burning and death, or this is postmortem. Now burn then death. Burn with death is can be an accident also, right? death due to burning. And death, then burn, that means obviously a dead body, how it get burned, there is a chance that there are some homicidal tendency behind the whole incident. So you need to understand whether it is antemortem burn or postmortem burn. In antemortem burn, there is presence of inflammation, blisters, higher level of carbon monoxide in blood, presence of soot particles in trachea. That is very important, because when burning was occurring, the patient was alive and patient inhaled, breathe in. And when there was when the patient herself, because she was alive at that point of time, then carbon monoxide in the blood or the soot particles got into her trachea, got into her airway. But if death occurs at first and then the body is burned, you cannot find these features, because when and and soot particles are released, already the body, I mean the patient, the person is not alive. So there will be no breathing in or inhalation. And that is why there will be no inhalation of carbon monoxide and soot particles or presence of soot particles in the airway. So this is evident in antemortem burning only. But in postmortem burn, only blisters can be found with exudates insides. So in this particular case, you found blisters containing exudates. First death occurred and then burning occurred. So this particular case belongs to postmortem burn. Now postmortem burn has some may have some homicidal tendency. Also, this also in antemortem burn also can have homicidal tendency, obviously, but it has more tendency because death has occurred, was burned, and then the body was presented, and the family members were representing that the female person died because of burning, but not because of burning. Her death was occurred due to something else, and then she was burned just to mock the whole situation, that she was died because of burning. Now there is deepened red horizontal line around the neck along with hyoid bone. This is very evident. Broken hyoid bone and deepened red horizontal line around the neck. This must not be these are not connected, associated with burning. Is it associated with strangulations? It implies that there was a pressure on the hyoid bone, right? Which is possible whenever someone or something had pressed the neck. Maybe it was homicidal or suicidal. Neck has to be investigated, but due to burn, the skin is difficult to understand. So as for our MCQ, cause of death is asphyxia. It's not burning. It's not inconclusive as well. Again, this burning. So A and D is crossed. Also C, we can conclude that there is asphyxia. And it is postmortem burning, because blisters containing exudates. In antemortem burning, there should be inflammation, there should be blisters without exudates, higher level of carbon monoxide in the blood, and presence of soot particles in the trachea. Specifically, there was no carbon monoxide in the blood and presence of soot particles in the trachea, as there is no mention of those features in the question. it's a postmortem burning. Now we can conclude the family members have concealed something. We are not sure that whether it is homicidal or suicidal. We are not sure. That has to be investigated by police. Actually, your the work as the doctor is that you need to mention what you can find, whether it is post-mortem burning, whether it is anti-mortem burning. You must not give any, or if you can understand homicidal or suicidal, then it's something different. So like from hanging we can understand, but without evidence there is no need of passing any any confirmed points. Rather, what we can find, still whether it is homicidal or suicidal is not clear, but must be investigated to bring new findings about the body for further conclusion. So anyway, as for the MCQ and the description, we can till now we can say that the cause of death is asphyxia and it is post-mortem burning. Okay. Okay, the next question. After a motorbike accident, a 20-year-old male complains of painful pain on the right hip, and X-ray was done as shown here. Probable diagnosis is very evident posterior dislocation of hip. Posterior dislocation of hip. You see the two side and compare. Patient is telling it's the right pain on the right hip. So can understand that right side is abnormal. Right side is abnormal, and you check here. This line is vital. This line is vital. There's this line in the X-ray is vital for concluding the normal joint. But you see the head. So the head of the femur has gone inside. That means posterior dislocation. Posterior dislocation. Okay, it's not written the X-ray features. So head has gone inside and has gone inside the hip bone, and there will be rotation of internal rotation as well to have posterior dislocation of hip, and that's why the head is inside the hip bone. Okay, so it is the most common type of hip dislocation in adults and children, and usually in road accident it occurs. Dashboard injury also it can be occurred, and this is the position of the hip at the time of injury that decides the pattern of injury. And another thing is, you need to remember Thomas splint is used for posterior dislocation of hip. Thomas splint is used for posterior dislocation of hip. And for diagnosing the dislocations, you need to see this joint line. This joint line, whether it is obliterated or not. Here you can see it's clearly obliterated and internal rotation has occurred, and that's why we can come into conclusion that posterior dislocation, there is no fracture anywhere. Femur neck fracture is not there. Okay, so we can go for posterior dislocation of hip. And always remember Thomas splint can be used. This is the typical Thomas splint. For IBQ also this is good question. Okay, so anyway, this is all for the case discussions.
Thank you.
Thank you. And on Tuesday we will summary class, same
Sure.
timing.
Okay. Sure.
Okay.
Thank you.